Late nights, skipping the cleanse routine, going to bed with your makeup on. We can put our skin through a lot over the years. Thankfully, Kotia has combined deer milk with powerful actives to create skincare that genuinely keeps up with your lifestyle. And thousands of Aussie women are already obsessed. Keen to see what all the fuss is about? Use code MAMAMIA20 for 20% off your order. Kotia, because your skin deserves something extraordinary.
Welcome to The Kick, your expert-led podcast helping you explore and learn everything about getting pregnant, pregnancy, birth and becoming a parent.
On the podcast and our online pregnancy program, Grow My Baby, we share my experience of helping more than 4,000 babies to be born.
And our experience of running a women's health clinic and parenting 4 boys.
We're here to help everyone to feel empowered in pregnancy and birth with real-life practical information.
Welcome everyone, I'm Brigid Maloney and today we've got another clever cookie on for you. We're going to be talking all about women's health research and the surprising issue of hip pain specifically for women in pre-pregnancy, pregnancy and postpartum. And the guest we've got on today is Associate Professor Joanne Kemp. She's the Deputy Director at the La Trobe Sport and Exercise Medicine Research Centre. She's the lead of the centre's hip pain research program. She is the Academic Director of the La Trobe University Clinical Trials Platform and also a sport and exercise physiotherapist of 30 years plus experience. She's a Fellow of the Australian College of Physiotherapists and editor at the British Journal of Sports Medicine. She has more than 160 publications and she's been able to get more than $13 million in research funding. Her research program is focused on the management of hip pain in adults, especially interventions that can slow the progression and reduce the symptoms associated with hip pain and early hip osteoarthritis. I just want to remind people about our Black Friday sale. Now, we haven't been on a Black Friday sale ever, but we really wanted to give people the opportunity to come and join our program to get some expert information during their pregnancy. And it's on until December 1. So you've still got time. It's 20% off all our products. So that's the Getting Pregnant program, that is the Pregnancy and Birth program, and also the bundle, which is 2. So definitely jump on that. We'll also put those links in the show notes. Now, let's get to talking to Jo. Well, welcome, Jo. I'm so thrilled that you said yes to come onto our podcast.
Thanks for having me, Brigid. It's very exciting to be here to chat to you.
I want to tell the audience about your very, very diverse career. You're a clinician, a researcher, an educator. What really drew you into physiotherapy? And did you always imagine you'd end up in academia?
Yeah, that's a good question. So I've been a physio now for 33 years, I think, so that's a long time. And I didn't even want to do physio to start with. When I was at school, I wanted to do medicine, but then at the last minute, I decided medicine all sounded too much study, so I changed to physio instead, which I've been very happy with, but then I've done a lot of study along the way anyway. But no, I didn't really plan a career in academia. I was a clinician for a long time. I was a mum, have got 3 kids, so I took some time off, reduced to part-time while my kids were little, and then I think I then sort of got a desire to understand more about the patients that I was treating in my clinical practice. So started a PhD back around about 15 years ago and got into research that way, really just to try and answer questions that I was seeing in my clinical practice every day.
And Jo, you are on one of the world's sort of leading sports medicine journals as an editor. How did that come about?
Yeah, that's a great question. So I'm really lucky to be one of the senior editors on the British Journal of Sports Medicine. So that's the #1 ranked sports medicine journal. So I was fortunate enough to be invited to be part of the editorial, the senior editor team. So we have an editor-in-chief, Professor John Dresner, who's based in Seattle, and when he took over the role as editor-in-chief, he was putting together a team of people with sort of diverse skills from different parts of the world. And so he invited me to be part of his team. And so I've been doing that now for 5 years as one of the things that I do. And it's such a great experience and opportunity, because one of the things that John's really passionate about and that he sort of leads us along with his passion is to try and make sports medicine and medicine generally more equitable for groups that have been traditionally marginalised in research. So women is one of those really big groups. Women who are pregnant, women who have had children, women at later stages of life have traditionally been under-researched. So, and there's lots of different reasons for that we can talk about, but it's been really great to be part of working with him. That's where he's had that push to try and make research more inclusive for everybody and not just for the groups that have traditionally been included in medical research.
And when we're thinking about that, Jo, I kind of know the answer to this, I think. But when you first joined, how many women were co-editors when you first joined?
Well, actually, that's a really good question. So BJSM has always sort of led the field in this space. And so when I joined, John was the editor-in-chief, and there was 4 of us all together, and it was 2 men and 2 women. So there were me and one other woman, so it's 50-50, which is actually really unusual in that space, that traditionally men hold those senior editor roles. So I was fortunate enough to be part of that team. One of the studies that we did that we published in BJSM a couple of years ago was actually looking at women's positions in leadership in publications in journals, and we looked at how many women have first author positions, how many have senior author positions, what percentage of women are included in research, and we found that the number of women hadn't changed over 10 years and probably sat around 20 to 25% of all these things. So still underrepresented and not a lot of change, when we did the publication compared to 10 years earlier as well. So certainly it's a space that we still need to keep working on improving.
That is, I mean, I want to get into talking about research. We'll do hips first, and then we'll do the research bit. But before we get there, because you've just brought it up, that is probably one of the biggest issues. If women aren't there doing the research in the first place, then is it likely that a man's going to say, I'm just going to do a specific women-only research paper? Not to be too gendered about it, but you need women in there thinking, well, this pertains to me, so I'm going to get there and I'm going to do some research about it.
100%. And I mean, that's been one of the biggest issues, is that because a lot of the research has been led by men, and fabulous men and doing really, really great work, but I think it isn't often at the front of your mind, and women are more likely to speak up and include women in those decisions. And the stuff, some of the stuff that we've found is that you need to actually have actioned hard endpoints that you're aiming for, and things like quotas, if you're going to make a change, because otherwise the change won't happen. So you actually do need to put rules in place to really try and ensure things are equitable from a gender perspective, but then from other perspectives as well, whether you're including people with disability or people from low and middle income countries or from other sort of marginalised groups as well.
You must see a ton of papers come across your desk. So, you'd be at the forefront of, well, what's new, what's cutting edge in sports medicine. Our listener base obviously is women, but it's also pregnant women or women hoping to get pregnant. Is there anything that's coming across your desk that you think, wow, that's really interesting, that's novel, I like it?
We see so many interesting things, and at BJSM, it's really trying to get that balance between making sure that the research that we are publishing is of the highest quality, but also meet we actually have priority targets that we're trying to meet. So we do have priority populations that we want to see more research being done in. So women more broadly is definitely a priority population, but that can include sort of adolescent and youth women and women athletes, definitely women in those childbearing years. So pregnant women, pregnant athletes, women who have just had babies, and then women in later life, that is a real priority. So we're really trying to identify research that's really new and novel, but is also of really high quality and really speaks to the priority populations, of which women across all the different stages of life is definitely one of our priority populations. BJSM has an issue that's about to be published that is part of it's publishing the outcomes from what was called the FAIR consensus. So that's a consensus that was commissioned by the IOC, the International Olympic Committee, and it's 100% around female athlete health. And so there's a whole issue which has got a whole number of review papers and editorials and things that are all about preventing injury and managing injuries in women and women athletes in particular. So that's something to keep an eye out. BJSM in the last couple of years has published a whole bunch of different research on pregnancy in athletes and enabling women to exercise through pregnancy. So not just elite athletes, but women at all stages of the athletic sort of cycle, and also after they've had kids as well, how to keep women being able to play sport or participate in activity in a way that's safe, both through pregnancy and after they've had kids, to ensure that they're safe but also can maintain their participation and their physical activity and their health.
How great. I can't wait to read that. You'll have to keep us updated, Jo, when that one comes out.
Hit that arvo slump and fighting to refocus? Everything feels harder than it should. I'm Claire Murphy, and this is Well, your weekly wellness reset. No fluff, no fads, no woo-woo, just clear, expert advice to help you bounce back to your best. So whenever you need a second of self-care, join me and our resident GP, Dr. Mariam, for real talk on our bodies, minds, and how to live a healthier life. Listen now, wherever you get your podcasts.
I want to move to your sweet spot, which is hips. Your hips don't lie. I was thinking maybe we could call it that, but I might think of a better title by the time when this comes out.
But it's a good one.
Oh, yeah. What led you to go, okay, I'm going to start studying hips in women specifically? Like you've looked after people's hips, men, females, for a long, long time. So why have you then chosen, I'm going to now look at hip pain in women?
Such a good question, Bridget. And I think for me, it's a bit like that question that you asked about how did I even get into research in the first place. It's what I saw in my clinic and have seen for many, many years is, particularly once I really started to focus in on just treating people with hip problems, is I would have some days in my clinic where every single patient was a woman and I wouldn't even see a man. So my clinical practice really showed me that the burden of hip pain, just from what I was seeing coming through my door, was much higher in women than in men. Now, there'll be some selection bias in there in that because I'm a woman, maybe women patients feel more comfortable to see me and so on and so forth. But it really made me think that this seems to be a lot worse for women than men. And so then when I went to the literature and started reading about that, what the evidence shows us really clearly is that the burden of hip pain is much higher for women right across all stages of the lifespan. So from when they're sort of teenagers, like 11, 12-year-olds, all the way through to older women, the types of problems that they have with their hips are different at different stages of life, depending on a whole lot of things. And we can go into some of that detail if you'd like. But it's consistent that right across the lifespan, the burden of hip pain is much higher in women than it is in men. So more women are getting hip problems, and when they get the hip problem, they're affected in a much bigger way than men are as well.
Let's go into some of those practical sort of examples of how women are affected at different points in their life with common symptoms. So if people are listening to this and they've got pelvic girdle pain or some other sort of pregnancy-related thing, can you just describe what happens commonly?
Yeah, absolutely. So one of the problems with treating pain sort of in that hip and pelvic area is trying to work out what it is that's causing the pain, because there's such a big overlap. There's so many different things in that area that can cause pain. And obviously in women, it's more complicated there than it is for men, and there are more things that can cause pain. So the first thing to do is to try and differentiate what is causing the pain. So is it actually coming from the hip itself, so the hip joint, the ball and socket joint? Maybe it's coming from some of the muscles and the tendons and things around that area. Could be coming from their lower back. You can get referred pain. Could be coming from the joints in the pelvis. So we've got the pubic joint at the front and the sacroiliac joints at the back. They can both cause pains. And then there's all of the internal pelvic organs that can cause pain, and then there's the pelvic floor as well that can cause pain. So there's so many different things that could be causing pain in women that do require quite a specialised assessment, I think, to try and work that out, because it is complicated. And for some women, it can be lots of different things causing pain, so it's not just one single thing. But having someone who you trust that you can go and see to try and help you tease that out is really important, so that you don't waste time and money kind of going down the path of perhaps having treatments that you don't need, and you really, focusing your resources and time on the treatments that are going to be helpful for you. So it is complicated, and I think that the complicated nature of it is one of the reasons why for women the burden of hip pain is a lot higher than men. But I also think historically that women with pain in that area have potentially been dismissed, and we there's strong evidence now historically. Like the word hysterectomy comes from, is based on hysteria. So I think women, particularly with pain in that sort of abdominal, pelvic, groin, hip region, have often in the past been dismissed as well. So therefore, we haven't done the research that we need to do to try and understand why women are getting these problems and what are the things that we can do to fix it. And we still don't understand that. We still don't understand that intersection or that interplay between all the different possible causes of pain in that area and what the best way is to manage them. So, yes, I'm really motivated because I am a woman. Obviously, I see the women with these problems in my practice every day, and I can see the impact, the enormous impact it has, how it really messes up their lives when they have pain in this area. And we don't know enough about it, so we really need to try and understand more what's going on.
Would a woman who has pain pre-pregnant, more likely would that be exacerbated with pregnancy, or have you actually seen pregnancy resolve hip pain?
That's such a good question, and there's no way you can predict that. For some women, their pain definitely gets worse with pregnancy. Some women it doesn't make any difference, but for other women while they're pregnant, they're actually a lot better. And it's got to do, I think, with a lot of the hormonal changes that happen in pregnancy where your body releases relaxin, and so tissues that might have been stiff and tight are less stiff and tight. So it does depend a little bit on the source of pain as to whether or not that pain will be affected by pregnancy, and sometimes that can be negatively, but sometimes it can be positively as well. Some women will have pain before pregnancy. It'll go away while they're pregnant. It'll come back after their pregnancy. For other women, it might not come back after their pregnancy. So it really is variable, but it's not predictable, and you can't say for sure that everyone's pain will get worse while they're pregnant.
And if someone has pain in their pregnancy, where do they mostly complain of the pain?
So for women who are pregnant, often they'll complain of pain in the front of their pelvis, so right over that pubic area. And that one of the reasons for that is that where the two pubic bones come together in the pelvis, there's a little joint called the pubic symphysis, which is where the two pieces of the pelvis meet together, and it's a vertical joint. So it sits like that, and there are ligaments that kind of try and keep it together. And when you're pregnant, because your body's getting ready to deliver the baby, the ligaments around that joint can become softer, and so therefore that vertical joint doesn't have the compressive forces that hold it together. So activities, because it's a lot looser, activities that involve standing on one leg can cause a lot of shear forces through that joint, and so that causes a lot of pain in that pubic area. So that's a common site of pain. Another common site is around the back of the pelvis. There are two vertical joints, the sacroiliac joints. Exactly the same thing can happen where particularly things that involve standing on one leg could cause pain. So often it's in those, at the front of the pelvis or the back of the pelvis, but it can also be in the hip joints themselves, so more down in the groin area. Women may feel pain. It can be in the soft tissues of the buttock or even coming from the lower back. So pain can present in all those different areas, and for some women it can be multiple. They can have pain in lots of different areas.
So as someone that's specialising in hips, you consider that all part of your domain. Is that right?
Absolutely. Yeah, 100%. Because you can't, often there's an overlap, and often pain will refer. So the source of the pain might not be where someone's feeling the pain. And often you'll need to treat, and the body's like a chain. So something that happens in one spot will have an effect in another spot. So when we're talking about hip pain in women, we're not just talking about the ball and socket hip joint, but we're talking about everything around that area as well.
Oh, good. I'm glad we clarified, because I actually had very focal hip pain in pregnancy where I couldn't lie on my left side because it felt like a little pin was sticking into my hip. And then later on I had that treated, and I'm going to disclose I had that treated by Jo, who then when I was returning to exercise like 3 or 4 months after my fourth baby, and I went to see Jo. Jo, you tested all my muscles. You could see that there was such a weakness on my left side compared to my right, and I had to do lots of exercises, which I was partially good at doing. That's the thing, isn't it? You know, all of this
partially good is good.
It's still better than nothing. Good. Yeah. And that's the thing, like, you know, all of this takes work to correct. So let's just go there. Like, what would happen if someone, say, through, let's say, pregnancy and postpartum, they've got hip pain? What would you recommend they do as a first point of sort of treatment?
So I think the first thing is to find someone local to you, hopefully, who has some sort of specialised expertise in this space to try and help you understand what it is that's causing your pain, and also help set you on a path that's safe for you to do, given that you're either pregnant or you've just had a baby. So there's even though that area is quite complicated, there are a number of different diagnostic tests that can be done that help provide a little bit more detail on what the most likely source of pain is. So a sports physio, or someone with a physio with expertise is often a good starting point. If you have the ability to go and you can afford to go and see a physio in private practice, you don't need a referral to do that. But if you can get referrals to physios in community health centres and public hospitals as well from your GP. So I'd be going to see a physio first who has expertise in that area. And what they'll be able to do is they'll be able to firstly help you try and understand what it is that's causing you pain. So they'll sort of help create a bit of a diagnosis. And then the second thing that they'll do is they'll measure, a bit like you were saying, Bridge, measuring your muscle strength and things, is working out where perhaps your impairments or weaknesses or whatever are that need to be targeted, and then develop an appropriate treatment program for you that's tailored to both the type of problem that you have, the diagnosis, but also where you're at in your life, so what your strengths and weaknesses are. But, you know, if you've just had a baby, obviously the exercises that we would get you to do will be different to someone who is pregnant or someone who's never had kids or someone who had kids 20 years ago. So it's tailoring that program to suit you. And a really good physio should be able to also work out whether there's anything else that you need that's beyond their scope of practice. Because as physios, we are not, we don't have the scope to be providing prescriptions for medication, for example, or there are certain imaging tests that we can't order. So a good physio will be able to refer you on, whether it's back to your GP or to someone else, to get additional things that you might need above and beyond what they can offer. So that might be dietary advice, for example, or something similar to that. So physio is a really good first point of call, but I think it's making sure that physio does have some expertise in this space, and then also that they're happy to also refer you for extra things that you might need as well, sort of beyond what they can offer.
I remember you telling me about a case where you couldn't really work out why this woman was still having hip pain, and I wonder whether you'll remember this story. So still having hip pain, and you just asked her a casual question like, when do you get it or something, and is it cyclical? And she said, yep, pretty much every month. And you sort of worked out, hang on, this is linked to your menstrual cycle. And you sent her off to a gynecologist, and tell the audience what they found in that.
So this was actually quite a number of years ago, and this was one of the things, I think one of the people that really triggered me to thinking about there's more to this, like you have to think bigger picture. And but she ended up, we tried all the normal physio things. So we gave her exercises, and I think she had scans on her hip and all sorts of stuff, and didn't matter what we did, her pain wasn't getting better, and it was definitely related to her cycle. So it was up and down, basically fluctuating in line with her menstrual cycle. And then I think she mentioned that she had a history of endometriosis, and so I sent her back to her specialist at the time, and I think they ended up doing some sort of surgery on her where they identified that the endometriosis had actually grown down into her hip joint. So it wouldn't matter what I was doing as a physio, that would make no difference at all. She needed to see her gynecologist to get that specialised treatment. So I think that's the thing, that no matter who your health practitioner is, whether it's a physio or whatever, is that we're all part of a bigger team and we all have different skills and expertise, and it's the really good clinician will be able to identify when something's beyond their scope and where they need to bring in other members of the team to try and help people.
Parenting podcasts can be a bit earnest. Parenting Out Loud is not that podcast.
This person who I may not agree with politically is trying to talk about integrating children, not just into his professional life, but into public life.
I have referred to myself as one and done. That article did make me rethink the term.
It took about 11 seconds for this to go viral.
Oh God, is this the ejaculate one? That is deranged and I love it.
Parenting changes the way you see everything. Parenting Out Loud takes the big conversations of the moment and puts them through that filter.
Because if parents are thinking about it, we're talking about it.
Parenting Out Loud. Listen weekly wherever you get your podcasts.
I love it that you've segued nicely into like this multidisciplinary team, because this is how we got involved again, isn't it? So I want to talk now about your research. We do talk a lot about on this podcast about how women's health is just under-researched. Could you shed a little bit of light? You already said about women being underrepresented in the actual authors of the papers, but there's such a small percentage of research funding that's spent on women, isn't there?
Yeah, absolutely. So historically, sports medicine research is sort of my area, but I think it cuts across a lot of medical research that, the number of papers, probably around about roughly 20% of research is done in women. So that's papers that can be research studies that just involve women or studies that involve men and women, but it's really, really low, and particularly studies that focus on specific issues for women as well. So the representation of women as participants in research has been really low. And historically, a lot of that was because when you're doing research, it's really important that you can replicate things and that things are scientifically sound. And one of the problems with women is because we have these menstrual cycles that come every month, is that how a woman presents today might be different to 2 weeks' time or 4 weeks' time or 6 weeks' time. And so historically in research studies, a lot of the time they just excluded women because they didn't have to take that into account.
Yeah,
so
we're too hard. We're too hard. We're going to exclude that. Yeah,
too complicated. Exactly. Yeah. So, a study on heart disease, for example, done a long time ago, was only done on men because it was too hard to control for menstrual cycles and understand how that impacted on things. So that's why historically in medical research women have been excluded, because it just adds a level of complication that makes it easier to not include women. But we now know that women present across a whole lot of medical conditions very differently to men and need different treatment to men. And it's a gap that I think is getting better, but is still nowhere near fixed.
And just to further sort of prove that point is that even pregnant women, I think it's down to like 4%. So even in women's studies, often the pregnant women are excluded too, because you're even more difficult. So we're not going to go there.
Yeah, I totally. And people don't want to and I can totally understand this. People become very risk averse with it's a bit like exercise and sport for pregnant women, is that it's a lot easier to say, no, don't do it because it's unsafe. You're better off, don't want to take the risk. But what we now know is, say, exercising pregnant women is that if a woman is already doing that exercise, then it's perfectly safe for her to keep doing that, except for exceptional circumstances. But I think historically, again, we've been risk averse in not wanting to involve pregnant women just in case something goes wrong, where often I think it is actually safe to include pregnant women in a lot of things.
We've joined forces to develop the Ballarat Women's Cohort study. Can you tell the listeners what that is?
Yes, absolutely. So I'm super excited that we've joined forces, and this has been something that we've been talking about for a few years now, so it's great that we've finally been able to do it. So the Ballarat Women's Cohort study, it's part of a suite of studies that we've been able to have funded to do. And the nice thing about this funding is that I can choose how it's used, and so I can choose to prioritise studies in women's health. So the Ballarat Women's Cohort study is a study that we kicked off earlier this year, which is looking at women's health variables across the lifespan. I have a specific focus on trying to understand better that intersection and interplay between hip pain in women and a whole lot of other women's health variables. But within that, we're also hoping to answer some really important questions around endometriosis, around hysterectomy and what happens to women after they've had hysterectomy, and a number of other questions as well. So this is a cohort study where any woman who is a patient of the Ballarat Women's Clinic can join the study, and essentially what we do is we take a whole lot of measures on the women at the point that they join the study. If they have pain in the sort of hip and pelvic region, we then ask them if they would like to participate in a sub-study within that study, where we will invite them in to do a number of hip tests, potentially have an x-ray taken as well, and ask them specific questions about their hip. And then there's some other sub-studies as well with a focus on endometriosis and outcomes for hysterectomy, etc. And then we follow the women up at 6 months and then again at 12 months. And what this information will do will really help us sort of fill some of these gaps and improve our understanding of what happens to women across different stages of their lifespan, and how all of these different problems can intersect to create certain clinical presentations. The other really exciting thing with this study is that we've just got ethical approval to go bigger with the study, so go beyond the Ballarat Women's Clinic, which is exciting. So we really want to keep this study. We started this study as well to really try and include women from regional and rural parts of Australia as well in research, because people in regional and rural parts have also been underrepresented. So it was a chance for us to really focus in on that area. But we're now really interested to include basically any woman who lives in Australia, who's interested in taking part in the study. There will be an opportunity now. So if anyone's listening and they really want to contribute to research, there's an opportunity now that you can join the study as well. And most of the study is just done through questionnaires online. There is, as I said, there's the opportunity for the hip pain sub-study for people to come into the clinic in Bellerat to be tested. So obviously if you live a long way from Ballarat, that might not be feasible, but you can still participate in all the other parts of the study as well, the questionnaire-based parts. And so we are hoping to get, hundreds and hundreds of women, maybe even into the thousands, participating in this study, because the more women that we have in the study, the more equipped we'll be to answer these really, really important health questions with our research.
And one of the reasons why we wanted to bring it onto the Kick Pregnancy podcast is we're hoping that we get lots of pregnancy data now too. So, just really opening it up to everybody. So I'm really excited and thrilled about where that could go. And also to, have little old Ballarat at the front. That's pretty great. That's great for regional and rural women. I want to explain what a cohort is study. So could you just give a quick explaining, because there's lots of different types of research. So what is a cohort study? What is a randomised study? And why did we choose a cohort study?
Yeah, so I think the two sort of study types that are considered to be the most robust or best quality in research are, if you're looking at studying the effects of a treatment, that would be a randomised control trial. So that's where you're actually deliberately testing how people respond to a certain treatment, and usually you would have two groups there. So you'd have the intervention group and then your control group, and what you're doing is comparing the differences. So trying to see how effective a treatment is, and people don't know what they're getting, which group they're in. So that's the randomised control trial design, and that is the best way to test the effects of an intervention. But if you're not trying to do that, which is what in this cohort study, we don't want to test the effects of an intervention. We are just trying to better understand the relationship between different variables and what happens to someone over time. And so that's where a cohort study is the most important design. So to do that, so that's where you are doing what we call prospectively following someone. So you're following them forward in time as opposed to going backwards and looking what happened to them in the past. So you're following them forward in time, and you are collecting a number of different variables to answer a specific question, which the question's usually around what's the natural history of a particular condition. So in doing the cohort study design, we can understand, what normally happens to people with certain health problems or certain health conditions, and how these different conditions interact with each other. Because once you understand that, from there you can then start to develop different treatment strategies, different ways of diagnosing problems as well. And so for us, that cohort study, prospective cohort to study design is the best way to do that.
Yeah. And if someone was thinking about joining the study, it's all questionnaires online. So could you just tell people how long they would expect to need to fill out that questionnaire?
Yeah, so look, it depends a little bit on how quick you are at answering questionnaires and also how many things you tick yes or no to, because within the questionnaire, if you say no to some questions, you don't go any further, whereas if you say yes, you will go further. But I think the quickest that you would get through the questions would be probably 15 minutes. And the longest that it would take someone to answer the question is probably around about 30 minutes. It might take a little bit longer for some people, but I think roughly 20 to 30 minutes is around about how long it will take to answer the question. So that's at the first time point. And then there's a follow-up time point at 6 months and 12 months. And they will be a little bit quicker because we don't ask all of the same questions again, because a lot of the questions that you've already answered, like, for example, how old you are or whatever, obviously we don't ask those questions again. So
I'm 6 months older, Jo.
Exactly. So
the
follow-up time points, that's right. So I'd say probably 20 to 30 minutes at the baseline time point, and then probably more like 20 minutes for the follow-up time points as well. So it is there is a bit of a time commitment, but it's so important that we get this data because we, before we set this study up, we did a little bit of a sort of scout around the world to see what else was happening in this space, and we really believe that this is a really unique study and that no one else that we could see is collecting this sort of information really specifically focused on women who come from regional and rural parts of the world, and with a real focus on a very detailed and comprehensive collection of many, many women's health variables that will really, I think, give us a unique opportunity to answer some really important questions.
And if anyone's worried about their identity, how is that managed through this process?
Yeah, look, that is such an important question. And I think particularly in this day and age, we really obviously need to know that everything will be managed. So the data that we collect in this study is collected through a platform called REDCap. So REDCap is an online software tool that is used by universities to collect research data. And so the data that's collected in REDCap is collected through the La Trobe University REDCap system, and it's stored safely within the university system. So that's a system that the university considers to be the most robust and secure system. Anytime that data is taken out for analysis, it's completely de-identified, so we don't know whose data belongs to who, so that those any identifying things are kept completely separate from any of the health questions that people answer. So there's no way that someone could hack into the database and get personal health data out. So the database itself is protected so that only the researchers who are listed on the ethics application to do the research can access that database as well. And they obviously have to have sort of passwords and all the usual encryption things as well. So while you can't be 100% certain that all data will be safe forever, I think this is probably as robust as it can be, because we are really conscious that people are sharing personal and sensitive health information, and so that we want to make sure that that data is as secure as it can possibly be.
Yeah, great. I'm super excited to be a part of this in any small part we play. Jo, you're the one that's doing all the heavy lifting, because I think that we have the opportunity to really make a difference. We have the opportunity to build more and more data that, not just we could probably produce lots and lots of published papers from this particular data set. I think it will have knock-on effect for years to come. And, one day they might be talking about the Ballarat women's cohort study back in 2025. And that makes me really excited, because it's just, as you said, it's just not out there in the globe yet. Yeah.
Yeah, totally. I agree 100%. And I think it's going to, most importantly, is it's really going to make the health of women better.
Yeah,
which is what we're trying to do.
Yeah,
and just give women the opportunity to live better lives and have better quality of life and participate in life more. And that's what we're trying to do. Sort of shine a spotlight on women's health and the importance of women's health.
And the importance of women and the role that they play in our community as well. So I think it was Michelle Obama that said our communities are only as strong as the strength of our women. And that's been sort of collaborated by a recent McKinsey research paper, which showed that even if we were to improve the lives and health of women, that it would have a financial global impact of $7 trillion or something like that. But, not overlooking the fact that actually women would be living much healthier, happier lives just because their health is understood.
100%. I totally agree.
All right, Jo. Well, I hope that you get all the data you need for hips as well. I love what you already do in the hip space for women, and I'm really looking forward to seeing what happens from the cohort study.
Thanks, Bridget. And thanks for the opportunity to talk, and also thanks for the opportunity to collaborate with you there. I think that, I'm just super excited. It's going to be such an important study, and I'm very grateful that you've let us into your clinic and let us collaborate. It's wonderful. So thanks.
Well, everyone, thank you so much for listening. I hope that you heard all you need to know about hip pain in women and how much we need to know more about hip pain in women. I hope you feel really compelled to join our Ballarat Women's Cohort study. As we talked about, anyone that is 18 plus and living in Australia, any woman, can join the study. It takes about 20 minutes to 30 minutes to do, and it will be your contribution to really improving the data that we have on women and see what those variables are in a woman's health journey on her future health. So thanks for listening. We'll put a link in the show notes as to how you can join that cohort study. We really look forward to your participation. Until next week, keep well, keep growing those babies, and we'll be back in your ears then. Bye for now. Hey, even though Dr. Pat is, a doctor, and we get lots of other doctors and other experts on our podcast, I just need to remind you that this podcast is for informational purposes only. We share lots of medical insights and experience, but everything we talk about is general in nature and may not apply to your specific situation. Please always consult with your own healthcare provider for your individual medical advice when you grow your baby.
Struggling with the anxiety that comes with adulting?
Or maybe you've suddenly become the parent to your parents.
Wondering if you might have ADHD, but unsure if or how to get a diagnosis?
I'm clinical psychologist Dr. Anastasia Horonis.
And I'm Ashani Dante. We're your hosts of But Are You Happy?
Bringing you all the self-development and mental health information you actually need.
New episodes drop every Saturday morning.
Just in time for your hot girl walk.
So tune in to But Are You Happy? The podcast where overthinking finally gets the spotlight it deserves. Made in partnership with Medibank.